Hello, Dr. Jeroen Bax. Thank you very much for coming to India for attending this prestigious conference of the Cardiological Society of India. And in fact, we are very glad that we are associated with the European Society of Cardiology in a great way, and we are having real good relationship. Now, so far, my purpose is concerned to interview you is basically to have a chat between the two organizations, and I'll speak on behalf of Cardiological Society of India some of the questions that will be put to you in relation to the organization to organization relationship. So thank you very much once again.
First of all, I'd like to thank you for hosting us, and I'd like to congratulate you with a fantastic meeting, 70th anniversary. It's just spectacular. I was in the big hall looking at the lectures. The level of professionalism is so high. The infrastructure is so perfect. I think really big congratulations.
Thank you very much. It's because of the team effort of the whole organizing team as well as the scientific committee team. They have done a splendid job in this conference, and really we are proud of them as well. So far, our concern is in relation to the relationship between Cardiological Society of India and the European Society of Cardiology. We are having a long relationship. There is no doubt about that. We are organizing CSI at ESC conference, and you are also being part of the ESC at CSI conference. So these joint sessions are going on for a long time, and really we are very much happy to have that. But do you think any chance of increasing the relationship to a higher level?
Well, first of all, I think we have a very good relation, and as you said, it's long-standing. We have been involved in a lot of things here with you, and likewise with us. I think these joint sessions are very good because they reflect very clearly how things are done here and how things are done in Europe, and what the difference is between these two. What I also start to see is that the ESC is becoming more of a global organization rather than a purely European organization. Next to India, we work also a lot with South America, with Africa, with Asia, and recently we start to reach out also more to Canada and Australia. So we aim at globalizing things and not coming from us, but more bringing the different cultures and societies together, where everybody's input is equally appreciated. So you will start to see over the coming years that we go more in the direction of global cardiology, globalization. You indicated the sessions are very good that we do, and it highlights how we do things and how you do things, but what are the other things we can do? I think there are lots of things we can do together. One is the things that is registries. We have very big registries in Europe, and with the globalization of the program as we do it, we actually start to invest more and more in bringing the registries from us to other parts of the world. So we have them, for example, in heart failure, atrial fibrillation, STEMI, non-STEMI. That could be very interesting to share that with your country. To some extent, we are exploring the possibilities there. I think we also work together with our guidelines. Our guidelines are becoming more and more globally appreciated, and there is a possibility. What we have just done during my presidency is that we opened up the membership of these guidelines. Every guideline usually consists of about 20 to 25 people, and we included in some of the guidelines some person from Canada, some person from Australia, and others. That could be done with India in the long run as well.
Yeah, that's the major point I wanted to ask you. That so far the guidelines are concerned, the data generation that is being done in the European Union. Now, you are incorporating Canada or some other countries. Are you going to take the data from those countries? Say, for example, we want to partner with ESC and for that matter with you. And if we are to share data, so how that can be actually proceeded further?
Okay, first of all, the guidelines are mostly based on the large randomized trials, and they come from all over the world. They're usually coming from the United States or Europe, but they are more and more becoming global. If you look at the big heart failure trials, they're also done in other parts of the world. So there is this trend towards globalization. So for the trials, there's no discussion. What is interesting to discuss is the registries, because we have registries that are pooling all data from Europe, but we start to also reach out more to other countries. So there's a big opportunity to work with the CSI on collecting large data from here and looking, for example, at differences between Western and Eastern Europe and India. That would be very nice to work together on that.
This is a very good suggestion you have made. In fact, we have recently started one registry data collection, and that's of course in only part of the country. It's related to the acute decompensated heart failure as well as the ACS. This is covering around 4 states, but as you know, India is a very vast country with different geography, with different economy, and there actually the monetary considerations are also to be taken care of. So we are trying to find out some information. We had some information regarding the ACS with different data collection done from at least 3 or 4 states. Now, in that particular group, since we have started the data collection, possibly you can also cooperate with us how actually we should modify it if we can share the data with you.
Absolutely. Well, first of all, we've been having long experience with running registries. So the infrastructure that we have, we could share with you. That is one important thing, which will help you a lot. The second thing is that you talk about big differences within India, and I've noticed that in the several visits that I've done here. But if you look at Europe, because we speak about one Europe,
Yeah.
I often refer to that as the northwest versus the southeast axis. If you look at the northern western countries in Europe,
They're at high level.
they're very high level. If you move more southwards or eastwards, you see big differences. When I visited, for example, Bulgaria and other countries in the east, I saw lots of differences with the standards that, for example, there are in Germany. So we're not so different. You have the same geographic heterogeneity in possibilities and standards of care that we have within Europe. So that's something where we are quite comparable. And that will make it also easier if we would work with registries, because you have heterogeneous data.
That's right.
And we also have heterogeneous data. And you have to find ways to deal with it. It's not necessarily a disadvantage. I think it reflects the real world situation. If you go to South America, you see exactly the same.
Exactly.
And so only the United States is one country. But most of the parts in the world consist of a very heterogeneous standards of care. So if you would take part of the registries with the different situations in different parts of the country, it would fit exactly with what we already have.
Well,
I
in
think
this
it would
relation-
open your eyes and our eyes
Yeah.
in how big the differences are also here in this part of the world.
Now, in this relation, there is a very much relevant question that you are doing all these things for so many years, and you have attained some heights, and not only that, you are trying to implement them to the full strength.
Yeah.
Now, are there any barriers for this implementation? Are you facing some problem which we can actually take care of ahead of time?
Yeah, of course. We have learned, for example, if you write your guidelines, these guidelines are based on the available evidence. The best available evidence comes from randomized controlled trials. So let's take, for example, the ICD trials. If you look at patients at risk for sudden cardiac death with a low ejection fraction, below 30 to 35%. The trials have shown that with an ICD, specifically in ischemic cardiomyopathy, you do much better than without an ICD. And so it has become a class 1 indication. If we look at all these different countries in Europe,
Right.
the northwest axis can better afford this amount of ICDs than the southeast axis. And that's just a reality. And so the way we work with these guidelines, if they go to specific countries that cannot adhere for logistical or financial or other reasons, then these guidelines are a little bit modified, not that the criteria remain the same and the recommendations, but we put there, or they put there, a sentence that although it is a class 1 to do so and so,
That's right.
according to the economy in that local situation of that country,
Yeah.
this is not always feasible. So you can implement there these little sentences that given the availability, the recommendation is this. But that's what we learned.
I think that's a fantastic idea because the corollary part which is to be added in relation to our economy is going to help the people to a great extent, in fact.
And one needs to be realistic. I
That's-
mean, you can have all these guidelines, but if you cannot afford, then you need to acknowledge that. And there can not only be affordability, but it also implementation, the infrastructure. Some of the countries very rich, but the infrastructure is simply not good enough yet. And I think the guidelines say it already. The word is guideline.
Right.
And that means that it gives you a guidance for doing, but if local situations do not allow to do it, do not permit to do it,
It's not.
It's not the law.
Sanctum sanctorum.
exactly,
Yeah.
absolutely.
We'll have to modify it as per our
Absolutely.
need.
You adapt it to the local
Yeah,
situations.
yeah. That's fantastic, actually.
I think another thing where we could work together much is within ESC, we have more and more of these travel grants. And the travel grants are for younger individuals who want to train for some time in another country. We have scientific grants. We also have clinical grants. And you can apply for that in your country, for example. And then if you get awarded, you can go to a place that you have upfront selected. And last year we increased significantly the number of grants for young individuals to be able to visit places of what they had selected.
Right. So, how can we actually do that? I mean, from Cardiological Society of India, how can we go ahead with availing those kind of benefits?
I think on a national level,
Yeah.
you need to popularize that. So you can build links on your website to our websites
That will be fine.
where the dates for submission are. And what you need is that a young individual makes a connection with this or that hospital,
Yeah.
and together they submit this grant request. And that way we make possible that a lot of people can change from country to country. Usually they last for 6 months to 1 year. I think 1 year for me is the minimum to go somewhere and to have really benefit from that other situation.
Okay,
So
that's-
travel grants.
that's fine.
And another thing which is very important to remember
Yeah.
is that for your young generation, we give always 25 travel grants to our European Society Congress
That's
to
fantastic.
all the different countries. So you can apply for that, have young people apply for that.
Is there any age limit for which this facility?
Well, the
can
age
be?
limit is officially around 35, but in some countries, we see also in Europe, the education takes longer.
Yeah.
For example, in Israel. And then it would not be fair to say to them, you have to be below that age. So we usually target below 40 years, but if there is specific issues, reasons why that could not be fulfilled, then there is no problem. We make the exceptions to the rule.
So we have got enough scope for developing and improving our relationship with the European Society of Cardiology, and definitely, as per your experience and the duration of time you are experienced with, we will be benefited because we have started late. There is no doubt about that. But we are also catching the time.
Catching up very quickly, I would say.
We are
The technology is fantastic
Definitely,
here.
some of our fields are very, very strong. Our people are very strong in some of the fields like coronary angioplasty and all.
Absolutely.
But we want to give a sort of holistic cardiologic care to our patients. And definitely, ESC will be a very, very great organization to help us in that. And thank you very much for giving me this beautiful time to share your informations as well as the inputs, and let us grow to a higher level for the benefit of the patient. Thank you.
We look forward. Thank you very much.
Thank you.